Good afternoon. Thank you very much for joining us today on this symposium on recent advances in the assessment of pre-eclampsia. My name is Manu Vatish. I'm a Professor of Obstetrics at the University of Oxford, and let me take you very briefly through what the agenda is for today. So I'm going to talk a little bit and give you a little introduction, and then we have three speakers. We'll have Jenny Myers, who's Professor of Obstetrics and Maternal Medicine, who's going to be talking about implementation of PLGF-based testing experience from the Greater Manchester region. She's going to join us later, so you are able to ask questions using the Slido device, but she'll join us to answer those questions a bit later. After that, we'll go straight on to Ms. Shona Haslam, who's a principal biochemist at Lancashire, talking about implementation of pre-eclampsia markers and insights into assay performance and clinical models. And after her talk, we'll do a Q&A session. We'll have a break for coffee, after which Amy Kiley, who's the principal clinical biochemist in Doncaster and Bassetlaw, will talk about how to implement pre-eclampsia markers and insight into laboratory practicalities, and there'll be a Q&A session there. And then after that, Jenny will join us for a Q&A session at the end, where we will also be able to have a group Q&A session, and then the meeting will close. So let me tell you a little bit about, give you my introduction. So let me tell you a bit about myself. As I said, I'm a Professor of Obstetrics in Oxford. I'm also a consultant obstetrician, which means I'm a jobbing workaday, working on delivery suite, doing everything that every other consultant in obstetrics does. I'm also a clinical director for the Reproductive Health and Childbirth NIHR in the Thames Valley and South Midlands. And I'm also a clinical academic training program director for the Oxford University Clinical Academic Graduate School. There's some disclosures here, which I'm not going to go through, but you're able to read. And what we're here today to do is to talk about pre-eclampsia. And pre-eclampsia is one of these diseases that has fascinated me from the moment I first heard about it. And you know, for the bulk of people, it will be encompassed by this picture of the hypertension and the proteinuria, but it's very clear that the disease is much more complicated than that. And you know, there are disorders with the people notice increases in weight gain, there's visual disturbances, there's blood dyscrasias, there's stroke, and all these, if they're not identified in time, will lead to the patient ending up with eclampsia fitting, which is represented by this woman who's allegedly fitting at the bottom of this picture. So we have, for a long time, used hypertension and proteinuria as the major trademarks of the disease, but it became very obvious that this wasn't encompassing the heterogeneity of the disease. And in fact, NICE changed the guidelines to fit into that heterogeneity, disease heterogeneity. So as many of you will know, but some of you may not know, hypertension is as it always was defined, with proteinuria or evidence of other maternal organ dysfunction. And that can be renal dysfunction, renal insufficiency, liver dysfunction, neurological or hematological issues, or evidence of uteroplacental dysfunction. And this is where identifying patients with preeclampsia becomes a little more difficult, certainly in the community, which is fetal growth restriction or umbilical artery Dopplers or stillbirths. The commonest screening tests that we're going to use, or most people are going to use in the community, are still hypertension and proteinuria, because these other tests are usually done in secondary care. And so the problem with hypertension and proteinuria is that they're both poor in predicting the clinical onset of the disease and its progression. What do we know about the disease? Well, we know that the disease is focused around the placenta, and we know that there's an initial lesion localized in the placenta that occurs in the first and early second trimester. And what's driving that initial lesion, nobody really knows. And the figures above of angiotensin antibodies or NK cells or genetic factors or oxidative stress, nobody's really pinpointed what's driving that initial lesion, but we know that the disease manifests itself much later in the late second and third trimester, and that's where we see the pre-eclampsia and the IUGR and the preterm deliveries and fetal death and placental abruption. And for a long time, we have known that the placenta is releasing, thought the placenta was releasing material that might be causing this hypertension, proteinuria, and other complications. And over the last few years, focus has really centered on these two markers, soluble FLT1 and PLGF. So this is a bit of a busy slide, but I think it's trying to show how soluble FLT is involved and how PLGF are involved in the disease pathogenesis. So on the top left, you can see a result from a paper by Levine et al. In 2004, where they had a very large cohort of patients, and they measured soluble FLT in these patients. And in the blue line, you can see the pattern of soluble FLT release in pregnancy over gestation in women who have an entirely normal pregnancy. In the black line, you can see that the soluble FLT is significantly elevated in women who got preeclampsia. And in the red line, you can see that the women who had preeclampsia later had levels of soluble FLT that weren't as low as control, but weren't as high as the people with established disease. If we move over to the top right part of the slide, or the placental growth factor, you can see that in the same patients, PLGF, which is again in the controls is the blue line, has a slightly different pattern expression. So it rises towards the middle of pregnancy and then falls towards the end of pregnancy. And in the same patients who have very elevated soluble FLT, these same patients have very low PLGF. And in those patients who develop preeclampsia later, we can see in the PLGF it's lower than control, but not quite as low as it would be in women with clinical preeclampsia. So if we look at the bottom left slide, we can see that the placenta is releasing soluble FLT and PLGF, and in normal pregnancy, you have not that much soluble FLT and quite a lot of PLGF. And in preeclampsia, you have a lot more soluble FLT and less PLGF. And what does this mean, or what does this translate to for the end organs, and specifically the endothelium, is that in normal pregnancy, you have lots of PLGF able to bind to the FLT receptor that sits on the endothelium and promotes vascular health. And in preeclampsia, you have a lot of soluble FLT1, which acts as a mop for the PLGF and prevents the PLGF from binding to the endothelial-bound PLGF receptor, and that creates endothelial dysfunction. In Oxford, we've had a long interest in soluble FLT and PLGF, and so the things that we've done in Oxford are we defined as part of a multinational study that less than 38 as a ratio for soluble FLT PLGF was the cutoff for ruling out preeclampsia with a negative predictive value of 99.3%. We did the first interventional trial using soluble FLT PLGF testing, which showed improved clinical precision. We've done UK specific and global health economic evaluations. We've proven that PLGF and soluble FLT are both produced by the placenta in normal pregnancy. We've done systematic reviews and meta-analyses of both soluble FLT PLGF and PLGF alone in preeclampsia testing. Together with Tim James, we've looked and we've published the specimen requirements of preeclampsia markers. We've recently demonstrated the performance of a ratio above 85 for ruling in preeclampsia within 4 weeks. And we implemented routine use of these biomarker tests in 2018, and we developed the Oxford protocol, which was the protocol that we used to initiate routine testing, which you can see here. And actually what you're seeing here is our COVID version, which has been raised from 20 weeks to, rather than 20 weeks to 34 plus 6 weeks, it's now 20 weeks to 36 plus 6 weeks. And you can see that we can assign a risk to different patients depending on what their ratio is. What I think is particularly interesting is that when you look at tech innovations, Lloyd Humphreys, who's the NIH Innovation Accelerator Fellow, showed that the average time for tech innovations to be adopted by the NHS is 17 years. But in the case of soluble FLT PLGF, The AAC and the ITP have provided a superb acceleration in timescales by speeding up adoption in a very short time frame. And it's because of this rapidity that we're able to have meetings like this, where we get experts talking about how the test works and how to implement it and what the biochemistry means. So the speakers that we have today are Professor Jenny Myers. Jenny is a professor of obstetrics and maternal medicine at the University of Manchester. She's also an obstetrician like myself, and she works on the labour ward of a busy tertiary unit with more than 9,000 deliveries, and she leads the diabetic, renal and hypertension service. She also leads 2 translational research clinics. She leads a portfolio of clinical and laboratory science studies, which looks at vascular and placental biology, and she's the lead site investigator for a number of multi-centre studies related to hypertension and diabetes in pregnancy. She's the chair of the Northwest Pre-eclampsia Guideline Group, and is the maternal medicine representative for the British Maternal Fetal Medicine Society. Our second speaker is Ms. Shona Haslam. She's the principal clinical biochemist at Lancashire Teaching Hospital. She is an honorary lecturer at Manchester University. Her main interests include the use of pre-analytics and automation, and she has a keen interest in both immunoassays and endocrinology, having published in the field. And additionally, Shona is a regional clinical champion through NHS Innovation Agency for Preeclampsia Markers, and has been an early adopter. And because she's an early adopter, she's been able to support other sites with their test introduction. And in November 2020, Shona became a specialist committee member on the Diagnostic Advisory Committee for the update of the PLGF-based testing. Clinically, one of her interests is to define novel roles for clinical scientists in patient-facing services. She also runs weekly lipid clinics with other clinical scientists and endocrinologists. And the last speaker we have is Miss Amy Kiley, who's a principal clinical biochemist at Doncaster and Bassetlaw Teaching Hospitals. And Amy is a clinical biochemist who's responsible for leading the special chemistry and immunology sections, and she led the laboratory implementation of soluble FLIT PLGF testing on the Roche 411, working in collaboration with clinical colleagues in maternity services on 2 hospital sites. So without further ado, I'm going to now move to Jenny's talk, who is going to give us an overview of preeclampsia biomarkers.
Good afternoon, everybody. I'm Jenny Myers. I'm Professor of Obstetrics and Maternal Medicine in Manchester. And this afternoon I'm going to talk about PLGF-based testing for preeclampsia and a little bit about our experience in the Northwest. So a couple of disclosures. I have done research studies related to both Roche and Quidel platforms for PLGF-based testing. I've contributed and continue to contribute to the NICE Diagnostic Assessment Guidelines, and I've led a team within the Northwest to implement angiogenic biomarker testing across hospitals in the Northwest, and I'm also a co-investigator of the PARROT-2 study, which I'm going to mention briefly at the end of my talk. So I'm going to go through some of the evidence, not all, but some of the evidence behind the use of PLGF-based testing for preeclampsia. I'm just going to touch very, very briefly on testing and evidence in other situations, particularly fetal growth restriction and stillbirth, and a couple of cautions. And then I'm going to talk about implementation of the test across the Northwest. So I think many of you will be aware with this kind of schematic, which is how we kind of think about the pathophysiology of preeclampsia. We know that in preeclampsia and the related condition fetal growth restriction, or FGR, that there is some element of placental damage which may arise from a number of different causes. And that placental damage in pregnancies complicated by preeclampsia is associated with the release of circulating factors from the placenta into the maternal circulation. And those factors cause an activation of the maternal vascular endothelium, which give rise to the clinical syndrome that we all know as of hypertension and proteinuria, with other end-organ complications. And soluble FLIT, which is an anti-angiogenic marker, was first discovered by a study led by Ananth Karamanchi, who identified mRNA signal within the placentas and demonstrated that soluble FLIT was significantly elevated in its expression in placentas from women who had developed preeclampsia. And that was led by, after that initial lab-based study, there was then a cohort study which demonstrated very convincingly that the anti-angiogenic factor soluble FLT, which is on the panel at the bottom, was very significantly increased in women who were going to develop preeclampsia, that's the red line, and those women who had preeclampsia. And then the pro-angiogenic marker, which is placental growth factor, or PLGF, was significantly lower in women who had developed preeclampsia, and that's the black line in the graph panel at the top, and also lower before women actually develop clinical signs of the disease, which is shown in the red line. You can see it falling off more quickly than in those women who went on to have normal pregnancies, shown in the blue line. And so that led a whole amount of research which contributed to the demonstration that high levels of soluble FLT and low levels of PLGF were biochemical markers of that placental damage. And basically, lots of us then went on to think, could these biomarkers be used to improve the diagnosis of preeclampsia and perhaps diagnose the condition before we were able to see those clinical features of the syndrome, which are a bit later on in the pathophysiology. And so over the last 10 to 15 years, an enormous amount of research is being done in this field. Now, many skeptics might say they don't need a new way to diagnose preeclampsia and that they're very good at diagnosing preeclampsia. And that may be true, and in lots of circumstances the diagnosis is not ambiguous, and women present with very significant levels of new hypertension associated with proteinuria or perhaps other abnormal features, and the diagnosis is certain. But there's a whole load of other women where the diagnosis is not necessarily so straightforward, particularly the first time a woman presents. We know that hypertension is the most significant and most common reason for women presenting to antenatal services, with around 1 in 10 pregnant women having some episode of suspected or confirmed hypertension. But amongst that group of women who have confirmed hypertension, only a proportion will actually go on to develop preeclampsia. And so an enormous amount of our antenatal care is focused at a group of women who actually perhaps don't need such close surveillance. We also know, and we all have seen cases of the presentation of preeclampsia being very atypical, and perhaps women having very significant complications without really necessarily meeting the full diagnostic criteria. Perhaps their blood pressure didn't quite meet 140/90, for example. Our current diagnostic criteria are based on thresholds from continuous measurements, and that's really important. So a woman with a systolic of 139/89 doesn't meet the current diagnostic criteria, but a woman with a blood pressure of 140/90 does. And that's the same for many, many conditions in medicine. And it makes the diagnosis very challenging. And perhaps most importantly is that women who have pre-existing hypertension and or kidney disease, the diagnosis of preeclampsia driven by placental damage causing changes in the mum, is that diagnosis almost impossible to make when women have already got hypertension and or proteinuria. And that's a place where these new diagnostic biomarkers potentially make a huge difference. So one of the first studies which demonstrated the utility of these biomarkers was a study called the Pelican study, which was run by Andy Shannon and Lucy Chappell at King's College London, and Manchester was one of the participating centres in that study. And we recruited a number of women who presented to maternity services with suspected preeclampsia. And they had their placental growth factor measured, and we demonstrated that in those women who went on to develop preeclampsia requiring delivery within the next 14 days, that PLGF-based testing was able to identify the vast majority of women who were going to develop a complication. And remember, this study was blinded, so the clinicians didn't know the result of the PLGF-based test at this point. But really importantly, the negative predictive value in this study was very, very high. And so if you had a normal PLGF-based test, the chance of developing preeclampsia within the next 14 days was very, very low, meaning that women could be safely returned potentially to normal care. Whilst the Pelican study was going on, across Europe, the prognosis study was going on, which used the Roche platform to measure soluble FLT and PLGF. And they did another large study with 500 women in the initial sample and another further 500 women in the validation set. And they demonstrated some rule out and rule in thresholds with almost identical diagnostic performance as had been previously shown, or was also shown in the Pelican study. So the negative predictive value, so ruling out preeclampsia, was extremely high within 7 days, and also very high within 4 weeks. And so both of these studies together were looked at in detail by the NICE Diagnostics Assessment Panel, who, on the basis of those studies and other information, produced a guidance that said that we should be using PLGF-based testing to rule out preeclampsia in women presenting with the condition between 20 weeks and 34 plus 6 days gestation. And that guideline came out in around 2016, but unfortunately the testing wasn't necessarily adopted by as many trusts as we would have liked, partly because of the costs associated with the test. So after the Pelican study and while the NICE guidelines were coming out, myself and Lucy Chappell and several other investigators set about trying to demonstrate the clinical utility of the test by actually using the test in real time. And so the Parrot study was performed across 11 sites in the UK, and that was a stepwise randomized controlled trial, which basically meant that across the 11 sites, each site was randomized to doing the test but not reporting the result to the clinicians, and then in a random order, units were changed over to reporting the test to the clinicians. And then we were able to compare the outcomes of pregnancies managed with the knowledge of the PLGF-based test compared to pregnancies managed without the knowledge of the test. And we were therefore able to look at the clinical utility. So across 11 UK maternity centres, we performed this stepwise cluster randomised control trial, which included women who entered to maternity services with suspected preeclampsia between 20 weeks and 36 weeks and 6 days, which is very relevant for using the test up to and below 37 weeks in our ongoing clinical practice. So in this study, we had 573 women who were managed with the knowledge of the test and 446 women who were managed using standard clinical care pathways. And you can see there was no significant difference in the gestation of which the pregnancy is delivered, which is really important. So we weren't delivering a lot of babies earlier in the group where we were using the test. And also most of your obstetric outcomes in terms of mode of birth were very comparable between the two groups. What we did show was that the time it took to make a diagnosis of preeclampsia was very significantly shorter in the group where the woman's pregnancy was managed with the knowledge of the test, and that was a very significant difference, with the diagnosis being made on average 2 days earlier. Also, very importantly, and this is perhaps the most important take-home message from the Parrot study, was that we showed a significant reduction in maternal adverse outcomes, which is really, really important. Now, fortunately, in UK maternity services, maternal adverse outcomes are very rare because we're very good at managing this condition and appropriately admitting and delivering women before they develop major complications. But even with knowledge of the very high quality management of these women, we still managed to show a reduction in maternal adverse outcomes, and presumably that's because we're making sure that the women at highest risk of developing complications are in hospital and being managed proactively and very carefully. The other thing that we were able to look at in this study was a cost utility analysis. So we were able to look at some of the costs around managing a hypertension pregnancy. So for example, outpatient visits, ultrasound scans, inpatient bed days, and neonatal length neonatal costs. And we were able to demonstrate that overall, using the test was associated with around £200 cost saving per pregnancy. So even when you factor in the cost of the test, which is somewhere around, for argument's sake, around £100 per test, there is a very significant cost saving to be made in the utilisation of this test, and that's really important. Around the same time as the Parrot-2 study was being done, Manu also did this study in Oxford, which was using the Roche platform, the soluble FLIT PLGF-based testing, and also randomised women to being managed with and without knowledge of the test, with very similar conclusions. What Manu's team already also showed is that the time to making a diagnosis was significantly shorter in those women where the test was available to the clinicians. Interestingly, there was no absolute change in the admissions in Manu's study, but what was really important was that the proportion of women who developed a complication or an adverse outcome related to their pre-eclampsia or developed severe pre-eclampsia, they were much more likely to have been admitted when we were using the test, as opposed to when the team were basing their decisions for inpatients based on standard clinical management only. So it was, again, evidence that we were getting the highest risk pregnancies into hospital for appropriate surveillance. This just shows the sensitivity and negative predictive value associated with standard clinical management, which is SEM. So clinicians were pretty good at detecting those women who were going to develop preeclampsia within the next week, and pretty good at ruling it out. But you could see that that performance was enhanced by using the ratio, and actually the ratio on its own actually outperformed clinicians. So clearly the ratio and clinician assessment is clearly the very nation for identifying those women who are at highest risk of complications. Just a quick caution that this test, PLGF-based testing, is not currently indicated. There's no current agreement or any evidence to support the use for testing for fetal growth restriction and or stillbirth in the absence of hypertension. And there's actually a bit of evidence that demonstrates that although there is some accuracy and some predictive value of PLGF-based testing for fetal growth restriction in women who don't have hypertension, the diagnostic accuracy is dramatically reduced. And so this is a test for hypertension complications of pregnancy, and clearly that encompasses an enormous number of pregnancies that will also be complicated by fetal growth restriction. But at the moment, there really isn't good evidence that this is a test that's useful to rule out growth restriction in the absence of hypertension. And again, in the context of stillbirth associated with placental dysfunction, whilst many stillbirths will be associated with abnormal soluble FLIT and PLGF, again, we don't have good evidence that using the test to protect against stillbirth, we don't have that evidence. So there are ongoing studies in that arena, but I think it's really important that we understand and we remember where the evidence is for the use of PLGF-based testing, and at the moment it is firmly in the arena of hypertensive complications of pregnancy, which overlap obviously with fetal growth restriction, but not growth restriction alone. So a couple of bits of data from our Manchester implementation. So this is implementation of PLGF-based testing in Greater Manchester, which was done following the NHS England support of testing back in 2019. And so, as I'm sure you're all aware, NHS England funded the test to be made available to all NHS trusts within England. And so we were already using the test at our hospital, at St Mary's Hospital in Manchester, but we wanted to try and help support and implement testing across Greater Manchester for those units that weren't already using the test. And I really need to say a big thank you to all of the people within Health Innovation Manchester, which is the AHSN within Greater Manchester, who really connected everybody across Greater Manchester to enable us to implement, and also to the providers of the test, enormous help from Roche in terms of helping to implement the test across Greater Manchester. So for those of you who don't know your Greater Manchester geography, these are the hospitals that make up the Greater Manchester footprint, and we have about 37,000 births per annum in Greater Manchester rather, going out towards Wigan, Bolton, Bury, Oldham and Pennine, Tameside, Stockport, Trafford, and ourselves in central Manchester at St Mary's Hospital. And we also cover and support East Chek and Macclesfield Hospital in East Cheshire. So this is data from and up to September 2020. So we've obviously got about another 6 months of testing to add on to this. But this gives you a kind of idea of the number of tests that have been done in hospitals across Greater Manchester. You can see that hospitals implemented the test at slightly different rates, which is what you would expect. And that it's certainly for our hospital, which is St Mary's on the Oxford Road campus, we were already doing the test and had been part of all of the research studies before. So we were obviously able to get up and running slightly more quickly than some of the other sites. And we had a big push on education, and we spent a lot of time going around the maternity units trying to encourage people to use the test, ask questions, find out more about it. And I think generally speaking, clinicians, midwives and doctors throughout the hospitals were very enthusiastic about taking up the test and very enthusiastic about learning more about it. In that right-hand column there, you can see the testing rate, and that's a very crude estimate of the number of tests that were done by each hospital as a proportion of the number of births in the time period in which they were doing the test. And it is very crude. Some women also had more than one test done, but it does give you an idea of the kind of spread of testing rates. I think the evidence would suggest that we probably ought to be testing somewhere between 5 and 8% of our population, depending on people's local setups and people's testing thresholds and where women come to. So some units perhaps doing a few more tests than perhaps is absolutely necessary, and that's all part of the learning curve. Other hospitals perhaps not doing as many. But it's useful for people to be able to compare and contrast and look at whether they're sort of sitting, how they sit compared to other units, and then go back and look at their own performance and their own data in their own hospital. So this is some data from Manchester Foundation Trust, or more specifically from St Mary's Hospital, which is one of the hospital sites within the Manchester Foundation Trust, and that just happens to be where I work. So we started testing under the ITP payment scheme in September 2019, and we've done approximately, up until February, about 1,250 tests so far. And I've had a quick look at some of the outcome data for about 9 months worth of that data, which covers around 445 tests in about 317 women, of which a handful were twin pregnancies. And you can see that even in our centre, where we were reasonably familiar with doing the test, you can see that testing rates have increased over the time period that we've been using the test. And I wonder if some of that uplift in testing might reflect some changes in clinical practice related to COVID, where we were really working super hard to try and keep women out of hospital as much as possible. And I wonder if that accounts for some of that uplift in testing. So in this graph, it just shows the spread of where the tests were being done. So some done presentation to triage, that's the right-hand bar there. The fifth floor in the left-hand bar that's where we do our specialist high-risk clinics, so it's a bit of a colloquialism, but that's where we do our high-risk antenatal clinics. You can see a third done in antenatal clinic, and a big proportion also done on the day unit, which would overlap with triage. And this is some data, kind of audit level really data, looking at what happened to the women following the test. So in all of these graphs, the red bar is those women who had an abnormal test where their ratio was high, and they were over that 85 threshold, which markates an abnormal ratio test. The orange line is women who had an intermediate, so between 38 and 85, and those women in green had a normal test. And you can see that what we would expect is that a small number of women with a normal test, so that's the green box at the top, we would expect that, and we would hope that those women aren't being admitted to hospital, whereas those women with an abnormal test are being offered admission where that's appropriate to do so. And you can also see in the graph underneath that some women do end up needing admission for hospital, even though they've got a normal PLGF-based test. And the reason for that often is because they've got something else which requires monitoring, be it diabetes or some other element of maternal disease. Perhaps they need admission for fecal monitoring. So it's important when people are auditing their local data that I think that you separate women admitted for blood pressure reasons solely, in which case you would expect the number needing admission who've got a normal test to be very low, versus women who've been admitted to hospital for another reason. We had a kind of subjective look, and the midwives looked at the end of the pregnancy to look at what was the reason for the admission, and was it appropriate that the woman had been admitted to hospital. And again, this is a little bit subjective, and this is audit-based data rather than research data, but you can see that generally speaking, women were admitted appropriately in the main, with just a small number of women being admitted with an intermediate ratio, that when we looked back in retrospect, perhaps those admissions could have been avoided. And then the other important question is what happens to the women after their test in terms of outpatient monitoring. And we've got pretty carefully defined guidelines on how often women need to have their blood pressure measured through the NICE guidelines. And so if women have got a normal PLGF-based test and their blood pressure is within a safe range, then they don't necessarily need their blood pressure checking for at least a week, and in some cases it would be appropriate to leave them at least 2 weeks. So was their blood pressure monitoring appropriate? And you can see that in the main it was, with some small numbers of women still having unnecessary, perhaps unnecessary blood pressure surveillance visits. But obviously we're never going to get rid of all of those antenatal visits, and there may often be other reasons for them. But in the main, what we want to do with this test is reduce the number of women who are coming for inappropriate blood pressure surveillance when we've got a normal ratio, and therefore we know that they're at very low risk of going on to develop pre-eclampsia or complications associated with the disease. More scatter graphs, I'm afraid. So again, the colour coding here is women with a red dot have got an abnormal soluble flip PLGF ratio test, and along the x-axis is the interval between the first test and the number of days till the baby was born. And for those women who had a repeat test, the interval between the last test and the delivery, and the number of days from the test to the delivery is there. And you can see there's, as you would expect, a big spread in terms of how long the pregnancies last from the testing. But you can see there's a real cluster in the left-hand corner for the women with red dots. The vast majority of women who have an abnormal test will deliver within a few days of having had that test done. What is really important to note though, and we've seen this in all of our studies and all of our clinical evaluations, is that there are some women who have an abnormal ratio where the diagnosis of placental dysfunction is absolutely clear and the diagnosis of preeclampsia is clear, but that certainly is not a reason to deliver the baby on its own. And so it's really important that we continue to educate our midwives and obstetricians that an abnormal test is diagnostic of the condition, but is not an indication to deliver the baby. And that diagnosis means that that woman mandates very careful surveillance with all of the usual tools at our disposal. So very careful blood pressure monitoring, very careful fecal monitoring in terms of scans and CTGs as appropriate, and monitoring for end organ disease. So looking at our normal routine blood tests that we would do for these women. But some women, those parameters will stay stable for many days, and in some instances they will stay stable for many weeks. We just delivered here on Friday a lady who'd had a PLGF ratio, soluble flip PLGF ratio of 300, who'd been pregnant for over 3 weeks after the initial test. So with very careful monitoring, it is possible to get a good gestation gain out of these pregnancies, but you do need to monitor the pregnancies very, very carefully and obviously be ready to act if there are changes in maternal or fetal condition. Again, this is audit data rather than research data, and these clinical diagnoses have not been adjudicated by an independent panel. But as a very high-level look at the diagnostic performance of the test since we introduced it as part of the ITP payment at MFT, you can see that the sensitivity and negative predictive value for all preeclampsia and preterm preeclampsia are again very, very good. And the test is identifying the vast majority of women who develop preeclampsia, and the negative predictive value in terms of excluding women who are going to develop preeclampsia is also very good. And there are various different ways to cut this data in terms of whether you do it 7 days after the test was done, or 14 days, or for the entire pregnancy. This is just for the entire pregnancy, so you would expect the negative predictive value to be a little bit lower, because it includes women who develop preeclampsia after that kind of 14-day window. I've written 2 false negatives there. We did have 2 women who developed preterm preeclampsia who had a ratio between 38 and 85, and actually really they're not really false negatives, because women with an intermediate ratio we know have about a 1 in 4, 1 in 5 chance of going on to develop preeclampsia, and mandate also a very careful level of surveillance. And actually in the Parrot study we showed that actually the biggest gains were actually in those women who had an intermediate test result, and slightly more close surveillance in that group of women is likely to identify problems sooner and prevent severe maternal adverse outcomes from happening. Very quick note on repeat testing. Currently not really any evidence to support the frequency or indeed the necessity for repeat testing. This just shows the kind of random direction in which the test result errors might go in terms of repeat testing within our own use. And I still I'm very unsure about what the value of repeat testing is, and we really need to await good evidence on that. And so this is just a quick plug for the Parrot 2 study, which is currently recruiting. We're running this study on the Roche platform at MFT, and we will be able to look at, by doing serial testing in this group of women, weekly or 2 weekly, we will be able to answer that question. And if anybody is interested in participating in the Parrot 2 study or wants any further information, please don't hesitate to contact us. And Jenny Sparks, based at KCL's email address. So thank you very much for listening. I hope you found that useful, and I'm very happy to take any questions or discuss any of those points any further. Thanks a lot.
Well, that was a very, very excellent talk by Jenny. You're more than welcome to use Slido to ask the questions, but as I mentioned at the beginning of the symposium, that Jenny will join us a bit later for a Q&A session. And so without further ado, I'm very pleased to introduce the next speaker, Mrs. Shona Haslam, and I'm going to hand over to Shona now.
Thanks, Manu. So today I'm going to talk to you about our experience at Lancashire Teaching Hospitals with the implementation of pre-eclampsia markers, and it's roughly split into 2 main sections. And we, as early adopters with the pre-eclampsia markers, get quite a lot of questions about how we implemented them. So hopefully today I'll be able to answer quite a few questions that people might have in this presentation. And if not, obviously you can ask more questions at the end. So just a brief introduction about Lancashire Teaching Hospitals itself. We have 2 hospital sites. We have one large teaching hospital site and another DGH site. And at the DGH site, it's a midwife only led service. And at the teaching hospital site, obviously we have a large site where we also have neonatal services as well, and we have around over 4,500 births per year between both sites. And a very, very quick introduction to clinical biochemistry at LTH. Again, we have 2 sites. We have biochemistry across both sites, and we have a hub and spoke model which runs across both sites. And we analyse around about 7 million tests annually. As obviously everyone will appreciate, this year has not been a normal year for analysing tests, so perhaps it's been a bit less this year. And as you can see from this picture, our lab is a Roche lab, and the picture on the left is our pre-analytics, and on the far right is is our analytical equipment, but we also have a specialist laboratory. We have LCMS equipment as well. So that's at the hub lab at the Preston site, and the trolley is a spoke lab. So the first part I'm going to talk about is the implementation side of the pre-eclampsia markers, and also about some models that we adopted to implement the pre-eclampsia markers. And something that's been published very recently, actually it's just been published in March, is a nice shared learning example that we've done at LTH, and it covers really just the biochemistry side of things. So not all the hard work that the obstetricians and the midwives done. It's just covering the biochemistry side of things, but that will give you a little bit more information about what we've done at LTH if there's anything else that you'd like. So it's on the NICE website if you want anything, and if you want to refer to anything else. But some of it's a lot of it's covered in this presentation. So to sort of go through it like the NICE shared learning examples do, you sort of talk about the reasons for change and why we wanted to implement the pre-eclampsia markers, and obviously it was the NICE Diagnostic Guidance 23. And this was first published in 2016 and was most recently up for review in February 2020, which said it needed a review. And the reason we wanted to sort of try and implement this was to improve the patient pathways for both mothers and babies at LTH. And we wanted to ensure that the right patients were in hospital and the right patients were sent home. We wanted to improve the diagnosis of preeclampsia, and also by improving this patient pathway, we hoped that we could reduce cost. And essentially, I mean, it's a difficult one, and this has always been a difficult one, but you're not going to reduce costs necessarily in biochemistry because you have to implement a test, but the costs would come in different places potentially, and this may be that by getting the right patients in the right place, you would improve outcomes for mothers, you would improve outcomes for babies, you would get outpatient costs down by again getting the right patients in the right place. So it would be these other costs that you would improve. So there would be the wider cost as opposed to just thinking in this sort of silo costing thinking. So that's essentially what we wanted to do. By improving the whole patient pathway, we could improve costs. And so what we wanted to do was essentially implement the SFLIT PLGF ratio. And this is just a very, very small amount or information about the SFLIT PLGF ratio. And I'm assuming that those people that have gone before me will have said a lot more about it. But according to DG23, PLGF testing can be used alone. So there are other tests available which allow PLGF testing to be used alone in risk stratification of pregnant women, or it can be used as a ratio with SFLIT. At the moment, all the SFLIT 1 and PLGF are immunoassays, and those that are available are the Roche Alexis, the Brahms Crypta assay, and there are some research-only ELISAs that are available for the ratio. But also, actually, there is a Siemens assay which is currently in development. So if you look on their website, that it's in beta testing, I think, at the moment. But again, it's not available and is not recommended by NICE. And currently the one that's recommended as the ratio by NICE is the Roche Alexis test. And again, like I say, I think there's going to be more people talked about the ratio prior to my talk. So I'm not going to say anything else about interpretation and things. So yeah, we'll just move on. So how we implemented the test at LTH? Obviously, we worked closely with the obstetrics team and midwives and obstetricians, and we provide a service in biochemistry to LTH. We provide it to antenatal clinic, to maternity wards, and to the obstetric triage teams at RPH. Occasionally will, and that's Royal Preston Hospital, and occasionally will provide it to Chorley, but like I say, it's midwife only. So by the nature of the patients coming to Chorley, they are usually very low risk, so they don't normally have pre-eclampsia. So usually we just provide the ratio test just to Preston, the Preston site. As I've already said, we provide the PLGF ratio test, and we have the Cobas E801 Roche analyzer. So this is the test that we currently run. And as these are our main analyzers, we provide a service which is 24/7 random access, and it's UCAS accredited. We implemented this test in February 2019, and as I sort of said in my opening slide, we were early adopters of the ratio test, and we were one of the very first people to get this going. And when we first started running the ratio, we were running at about 35 to 40 tests per month, and one thing that was really good for us was that when we actually got it live, we were able to use money that our trust have available for to use for NICE diagnostic guidelines and other NICE guidelines that are out there, that they have it available to improve pathways and things. So we can almost claim it back as biochemistry or pathology. So this is something that I think really worked in our favour, because we did try business cases that weren't successful in February, prior to February 2019, and we would have perhaps got it live a little bit earlier, but yeah, so we tried a slightly different tact of just getting it live and then using budget setting and money, claiming it back from the trust in a slightly different way, and just being a little bit more creative, using this trust's ability, our trust ability to get the money back through the way that they fund NICE guidelines and things in the trust, and it allowed us to get the test up and running slightly earlier. And this is just an example of how we got the test, how it was displayed in the wards and in triage. So this is something that I didn't do. This was on the midwives and the obstetricians. They created posters, and it just displays the patients who it was suitable in, and it's according to the NG23. So you're less than 37 weeks and you present with a new hypertension. So yeah, very standard use. This is just the pathway and the testing pathway for how we use the test and how things go through the flow through the lab, really. So the patient would be identified as requiring the test in antenatal clinic or on the ward, and then the midwife would bleep the lab. The patient would then be bled for the ratio and other routine tests, and obviously the ability to use the ratio test is very good, because you just need a serum sample, and if you're suspecting pre-eclampsia in these patients, you're usually going to take other routine tests anyway. Then the sample would be received in the laboratory. Our lab offers a 4-hour turnaround time. Our sample would then go in the pre-analytics, and then the sample would be analysed with an IQC block at this stage. And then, because the midwife had bleeped the lab in the first instance, we knew it would be coming down, so we could run their IQC, and then it can be released. So the sample obviously is analysed and the result is produced. The lab would then phone the ratio when it was available to the midwife, and the ratio is then available to the midwife and the obstetrician on the hospital information system, and then they are then available. They're then able to make a clinical decision on that result, and then the patient can then be discharged or admitted on the basis of that result at that So there's something else that happened sort of about a year later. We then were approached by one of our neighbouring trusts, Blackpool Teaching Hospital, to run the test for them. And so we run the test as a hub and spoke model for Blackpool Teaching Hospitals. And we've been providing this service since January 2020. And this next slide just shows how we run the same test, but in a very in a different way for Blackpool Teaching Hospital. And for a different trust. So at Blackpool Victoria Hospital, that's what BVH is, the patient is identified as requiring the test. The patient is bled for the ratio and for other routine tests, but if you follow this red arrow down on the left-hand side, the clinical decision to admit or discharge is made at this stage without the ratio initially. And then what happens at this stage is the sample is then received at the laboratory at Blackpool Victoria Hospital. The sample then is centrifuged and the serum removed, and then the sample is transported to Lancashire Teaching Hospital by routine transport. And then the routine transport, and this is the issue, and this is the reason why we didn't run exactly the same 4-hour turnaround and have exactly the same service as we did for LTH, is because the routine transport isn't as regular. So the routine transport only runs once a day. So they wait for the routine transport to come every day, and then we run it as soon as it gets to us. We run it as we would any other sample. And then once we get the sample, we analyse the result, and the result is then phoned. And as it says above, we have MPECs for request transfer. Then the result then goes straight back, and then the ratio is then available at Blackpool on their HIS. Then the clinical decision could be made. Now, depending on when the sample was taken, this could be the next day. Then the patient is contacted, and if the clinical decision has already been made, but then further clinical decisions can be made, or so that you can see that the clinical model is slightly different depending on what's happening, but both work very well. And not every situation in the different hospitals, they're not working in exactly the same way, but both are working very well. So some sort of key findings from both of these situations. In LTH, we have been running the test successfully at LTH for over 2 years, and it's embedded in routine care. Both the midwives and the obstetricians really like it. This is some clinical audit data from one of our registrars, and it showed that the use of the test allowed for 100% of the mothers with a result of less than 38 to be discharged home safely. And obviously, this clinical audit was done over a 2-month period, looking at all ratios that were done and comparing against DG23. So it showed that the use of this test allowed that these mothers could be discharged home safely. It did, however, show that we were perhaps overusing this test. And I think that was perhaps something we were doing. We had this test available, so we thought, why don't we use it? But we have also, in the audit data did show, we have also found that the ratio was useful for diagnosis as well. So we were using it for that, and it was useful. And just some key learning points also for us, that it's obviously really important to work with all stakeholders, the clinical scientists, the biomedical scientists, obstetricians, midwives. And obviously, I've just spoken about the lab side of things. I have not spoken at all about the masses and masses of work that the obstetricians and the midwives did to get this in place. The pathology reception staff to receipt all of this work, and IT setup. Clearly, the IT to get this set up is quite significant too, and we even have IT midwives who played a massive role in all of this too. One thing to consider is obviously the whole patient journey and the whole patient pathway, because like I said at the start of this, it's the, you know, when you're considering the cost of one thing, it may be quite costly to implement a test in biochemistry, but it has a big impact on the whole patient journey. And clearly one patient pathway doesn't suit all, but PLGF testing and the ratio testing can be integrated and can be useful and beneficial no matter what pathway or what form the pathway takes. However, we did note that clarity was required on how it should be used, and we were perhaps overusing it. So just now to come on to the second part of my talk, and something that I am asked quite regularly on, and this is some experience from a sample exchange scheme that I ran just before UK NEQAS was properly up and running. So at the time of our go live in February 2019, there wasn't an adequate EQA provision in place. Now, UK NEQAS did run the PLGF, however, it was just for first trimester PLGF and didn't have levels that were really appropriate for what we needed. So I set up this sample exchange scheme for this purpose. And what we really wanted to do was obviously have a sample exchange scheme, but also get accredited. And that was our main goal. So this sample exchange scheme consisted of 4 samples which were sent out in each distribution. The participants were asked to clinically interpret the results, and I'll show a report which says this the clinical details on the reports and how they were to interpret. Reports were sent back for the participants to see how they performed, and again, this was me doing it, so it's not UK NEQAS standard. It's my standard, which is not the same. Samples were anonymised maternal serum samples, and these samples were sent after one single freeze thaw sample by next day delivery. And I'm going to show some slides later about stability and how we determined how we sent the samples as well. It's got a bit squashed, this slide, but you can still read it, so that's fine. So the participants, we started with 3 laboratories, the initial laboratories who were running the pre-eclampsia markers, but with the implementation of the ITP funding, we very quickly grew to 13 laboratories. It consisted of Roche users only, but had E801s, E411s and E602s were all part of it. And my aim was to send samples every 2 months, but it was really just me doing it, so I didn't quite achieve that. But I nearly got there. And the samples were sent from June 2019 to January 2020. And I stopped in January 2020, partly because there was a pandemic, but also because by January 2020, and I was in contact all the time with Edinburgh UK NEQAS and Kathy Sturgeon, but they were sending samples that were 3rd trimester levels, and SFLIT was obviously on board as well. So we didn't need to do this anymore. If we just make that a bit bigger, that's great. So this is an example of a January 2020 report, and I've chosen the Preston lab. So this is nobody else's report. And by this stage, we had the most users. And you can see that when it's sent out, it was sent out in the December, and it does say that this is a serum from a pregnant woman, and it gives sort of an example of when assume it was from this certain week in gestation for interpretation purposes. And there's 4 samples, and it's got a breakdown of the SFLIT, the PLGF, and also there's a breakdown of the ratio as well. And it gives an overview of just like you would with any scheme, but your result, the target mean. The target mean is just the overall mean, and a bias. So the bias is your result relative to the target. there. So that, and you can see there was, for the PLGF, you can see that there was the N is slightly fewer, just because there was some failed to return. And you can see there's the bias is slightly larger for us, for one of them. But in general, you'd be quite happy with that. And this is taken from what we said, what I sent back from a January 2020 report, and it just gives you an idea of what the performance looks like. So all of them are set to the same, and this is an example of the percent bias relative to the mean for all of the labs. So all of the labs are a different shape and a different colour, and obviously every different sort of line of results is a different sample and a different concentration. And you can see that all of them. So if we take the S-FLIT, for example, all of them are pretty good and are sort of plus or minus 10%. And if you look at PLGF as well, they're pretty good. The one that's at around about the concentration, the lowest concentration, that's got the widest percent bias if you look at them all. And this is something that we've seen before, and there's a reference to a paper. There's a reference to a paper which I'm going to show a bit later, and this is something that we have seen before, where there's wider CVs and perhaps wider biases at the lower levels of PLGF, sort of around about less than 20, less than 30. But obviously, if you think about PLGF, it's obviously a very wide measuring range, and when you get to that sort of level, you may expect to see slightly wider differences. And then obviously, then we look at the ratio as well, and you can see that there's obviously a spread again there. So if I just I'll split this up a little bit further in a second, but we'll just look at the data, a bit further analysis from the data, the sample exchange. And in total, we had 92 single donation samples, which were distributed to a total of 13 separate laboratories over 3 distributions. And like I said, that was a total of 13 separate laboratories by the time we got to the end of it. And the first one was just 3. By the time I got to the second one, I think it was 8. Or 7, and so it very quickly ramped up, but it started quite slow. In total, we had 86 results which were returned, and there were 6 short samples or no results. And this little table just shows the mean concentration range of samples that were sent out. So for PLGF, the concentrations that were sent out range from 31.4 to 441.1. For the S-FLIT, it was 1,306.7 to just over 12,500. And for the ratio, it was 7.31 to 161.6. So you can see that they covered a good clinical range. So normal to abnormal. And definitely covered what you would see in clinical practice. And if we look at the percent CVs, in general, you can see that they're, for what is a sample exchange, they're okay, they're pretty good as well. So for PLGF, the percent CVs range from 4.15 to 11.09. Now, these percent CVs obviously do not relate to that mean concentration. The percent CVs are just the lowest to the highest that we saw. And that 11.09 does actually relate to that PLGF, that lowest PLGF of 31.4. So again, when I talk about, when you think about the lower end of the PLGF, that there is that wider variation that you see in the lower end of the PLGF. The percent CV range for S-FLIT, again, the highest percent CVs that we saw were 8.26, which is really good. When sending samples to 13 different labs, and when you're looking at then combining 2 different assays, the highest CV that we saw was 14.61. Again, which I think is really low. Is good when you're sending it to that many different labs. So coming back to looking at performance and bias, what we then did is we looked at analyze the level performance or the analytical platforms as a whole. So I calculated the mean bias for the individual platforms for each sample that was distributed, but I actually only did this for the latter two distributions because the first distribution there was only three labs, so there wasn't much point doing it for those two. It wouldn't really be a good thing to do. And when you do this, you can sort of see some reason for that spread, for that initial pattern that you see in those first slides, and you can see that if you look at the PLGF graph, you can see in the blue there's a slight positive trend with the 801 analyzers, and you can see a slight negative trend with the 411s. And I'm just saying there's a slight because we're only talking sort of 4 or 5%, and you can just sort of see the sort of 5% low negative with the 411s, and then the converse is true with the S splits, that the 411s are slightly positive and the 801s are slightly negative, and depending, I get this question quite a lot, that depending who you've done your verification with. So I've sent out quite a lot of verification samples, and depending what analyzer you're doing your verification with, so if you're an E411 doing your verification with an 801, you may see a slight consistent a constant bias, and that may be the reason. But actually, when you enter UK NEQAS and when you enter EQA, and you'll be okay. And this is something just to be aware of when you do your initial verification, really. And like I say, I get asked this quite a lot, and just bear this in mind. And obviously, this has an effect on the ratio. And this is the effect that you see, that the E411s tend to have a slightly positive bias, and the E801s have a slightly negative bias relative to the mean. And this is all just with the sample exchange data that I have up until January 2020. So what we did then is I wanted to look at sort of the clinical comparisons, because what we did is obviously we sent out samples, and we were able to look at how these were interpreted, and was there any difference in how people were actually interpreting these results based on these slight differences in bias and on an analytical platform basis. If you take all the results, so these 86 results that we had, and you compared the interpretation that they got based on the standard interpretations, and you compare them to the mean concentration, and you do the interpretation based on the mean concentration, the total correlating with the mean interpretation was 92%, and the total not correlating with the mean interpretation was 8%. And that corresponded with 6 reported results, and 4 of them were on one sample with a mean ratio of 86.8, and 2 were on one sample with a mean ratio of 36.2. Now, I obviously selected these samples on purpose because my intention for this sample exchange was to test the assay to see how they all worked. So I chose these samples to really test around these key diagnostic elements of it. So you may say I was being, slightly mean, but even around those sort of tight, tight means, and around those tight, cut-off points, it's not actually affected that many, that many clinical interpretations. And it was only the real borderline ones that it really affected. So even though you can see differences in bias, it really doesn't seem to affect that many clinical interpretations. So just to rest assured really that it doesn't affect it, and it's only borderline ones, which is what you would sort of expect anyway. It's just small differences. And I've just got a little bit about additional assay performance data, and it's from this paper just quoted here. There's some more in there, a little bit more verification data there too. This is just a little bit about low limit of quantitation. All this really says is that it might be slightly better based on between batch data than it says in the kit insert. So both PLGF and S-split might be a little bit lower. I don't think I need to dwell on that really. I get this asked this quite a lot, is sample stability. We tested sample stability, we tested frozen sample stability in A, so it was stable, both were stable for 6 months. We also tested room temperature, fridge, in the fridge, that's B, and it was stable in the fridge for 2 weeks. We tested at room temperature, that one just says for 24 hours, and it was stable, both were stable for 24 hours. And we also tested 3 freeze-thaw cycles, and it was stable for both were stable for 3 freeze-thaw cycles. And I've also done extended room temperature stability. Now I did this because we wanted to know about transporting samples around, particularly for verification studies, because I've been asked to send samples to various different places, and I wanted to sort of have a look to see how we could get them there without having to use dry ice and things, and also for the sample exchange program. But as you can see, over time, S-split actually looks pretty stable at room temperature, but PLGF starts to go off. It's not too bad, but some of those numbers, if you look at the tables, aren't that great. So it does start to go sort of up and up and up really. So that's something to bear in mind in terms of stability. This is something that we've looked at and hopefully will become less of a problem. And it's not, I'm not saying it's a problem because it's not, but will become even less of a problem, is biotin interference. There was something that was a really hot topic maybe about 2 years ago now, and we talked about it a lot. But so I just did a lot of spiking experiments with a lot of different assays, but in particular for the S-split and PLGF. S-split only seemed to have significant bias at 500, but PLGF appeared to have more significant bias at 60 nanograms per mil with the current assay that's available at the moment. But to put that in context, one of my colleagues has recently done a study looking at working up an LCMS method in-house, and has done a study of looking at 215 pregnant women, and all of them had a biotin concentration of less than 1.5 nanograms per mil. So that's just a tiny bit of context. And also, there's, like I say, there's other studies out there, but the Katzman paper looked at 2,000 paper, around about 2,000 people presenting to A&E, and only 0.5% of those patients had a concentration greater than 30. So, it's something that we need to know about, but actually, it's not a big thing out there. But I do know that Roche have a timeline for replacing their assays, and this is due. Both assays are due for replacement in October 2022, where the tolerance will be much higher. But I mean, it is something just to be aware of, but not something we need to think about all the time. So in conclusion, for this sort of second part, In general, the percent CVs were very good in the sample exchange, indicating good analytical agreement. And obviously the greater variability was observed for the ratio, and possibly down that lower end, less than 30, 25 of the PLGF. There was a slight difference in the mean bias between the Roche analytical platforms for both the PLGF, the S-split, and obviously then the ratio. The clinical comparisons revealed that this only had a small impact in a few of the borderline samples that are sent out to sort of challenge the assays. And it's clearly important to interpret the results with the clinical context, which is what we recommend with any assay anyway. And I just have a few acknowledgements then. Thank you very much to Biochemistry at LTH, and in particular Karen Perkins, who did the study for the biotin, and Rosalind, who helped send out some of the verification samples. And thank you to everyone in the obstetrics at LTH, and the people who wrote the verification paper with me, and all the labs who participated in the sample exchange. And thank you everyone for listening, and if you have any questions, fire away. Thank you.
Thank you, Shona, for an excellent talk. The questions are flying in thick and fast, you'll be pleased to hear. So the first one is are we able to indicate the minimum number of tests required to make this financially viable? What wastage occurs once kits are placed on an analyzer and tests are not done?
Yeah, I was really recently asked this actually about the economic impact of this test, and actually what we see at Lancashire Teaching Hospitals is very little wastage, and I think there's the 100 test kits, and because we run the hub and spoke model with Blackpool as well, we use those tests up in the 6 weeks that you get to use them, because it's got a 6 weeks on board lifespan. So when you think about tests, when you think about calibrators, when you think about IQC, when you think about EQA, when you think about all the tests you're going to run for patients as well. So we run patient samples, we run maybe sort of 45 of our own, and then we do Blackpool's as well. Over those 6 weeks periods, we actually don't have any wastage. So I guess one thing to think about is when you're thinking about setting up your service and thinking about numbers, you know, taking in all those things into consideration, take those into consideration, and there may not be any wastage, but also think about, is there anybody else on your patch that you could work with to reduce any possible wastage? But with our workload and the way we work with Blackpool, we actually see very little, if any, wastage in our economic model.
Okay. Somebody's asking about the details of the traceability of the assays.
Yes, yeah. I'm not 100% sure. I'd have to go back and look at the kit insert. I could have a quick look. Not sure if anybody on from Roche knows the traceability. Does anybody know the traceability of the assays from Roche?
Okay, while we're waiting for that. No. So choice of anticoagulants.
Off the top of my head, I don't know. It would be in the kit insert. Sorry, go on. Sorry, Manny.
Okay. Well, you see, I'm just reading these questions, so I don't know the answer to that either. So, choice of anticoagulants.
We use serum samples. It's serum, and obviously there's a difference. You know, the Roche and the PLGF and S-split is serum, and then the Credel, which is also recommended by NICE, that's a plasma. So there is a slight difference there. But yeah, it's a serum sample.
So the Roche and the Credel assays are serum only, correct?
Credel is plasma.
Okay, but the Roche is serum only. Okay.
Mm-hmm.
Are there any third-party QC materials available?
We still use the Roche QC, and we are unaware of this, but this has come back up again actually. So we're starting to look again, but we haven't found any. So it'd be interesting if Amy knows of any, and if she uses third party, but we haven't found any yet. But I'm sure it's on all the IQC providers' radar to sort this out. But we haven't got one for SFLIT yet.
And the EQA, somebody's asking about EQA scheme performance.
Yeah. This, in terms of EQA scheme performance, this is something that it's mirrored by the performance that I saw with the sample exchange, really. But when you look at sort of CVs for both assays, they're ever so slightly wider. And sort of around about this time last year, I did some work with Kathy Sturgeon at UK NEQAS Edinburgh. And we submitted an abstract to Focus, which is it's our national meeting for the ACB, but obviously everything's been delayed, so it didn't take place. But we're gonna it has been submitted again, and it will take place in June. So we will have an abstract which links the sample exchange that I've done and UK NEQAS Edinburgh data together. So if anybody is particularly interested to look to see how the UK NEQAS and the sample exchange work together, that there will be an abstract at Focus this year, bring that data. But if you do look at I didn't put it in my presentation, Kathy, if I can. But,
Okay.
But like I say, it will be there. But yeah, but the performance is similar, but as you would expect, because there's more labs, the CVs are slightly wider, but the data looks good.
What was the average or the range of turnaround times for the Blackpool Teaching Hospital?
Well, it depends exactly what turnaround time you mean, but for when it hit the lab, the turnaround time, we're always within 4 hours. But yeah, I'm assuming the person means, from taking the sample to getting the result back, because it worked in a very different way, and it would range from it would range usually from anything from sort of 4 hours to 24 hours, because of the way that the transport worked, because the transport went at 8 o'clock every morning, and it could range from, it could go potentially slightly over 24 hours for them to get the results back. And like I say, that model worked very well for them.
And in terms of, so somebody said here, I was led to believe onboard stability for the COBAS E801 was 16 weeks, and you mentioned stability of 6 weeks. Is the stability different for different platforms?
I'm not sure. It might have increased now. So that might be of when we just started. So that person may know better. I'm not sure. But if it's 16 weeks, then that's even better. And in terms of wastage, obviously there's even less.
Presumably, Shona, there's some guidance on the package insert for.
It's all in the kit insert. Yeah. So the traceability, the stability on board and everything's in the kit inserts. But yeah, that's
on the package insert. Is there guidance for stability? I mean, does it say, 6 weeks, 12 weeks? Does it give an indication?
Yes, it does. It gives exactly what you're supposed to do. That but everybody.
Okay.
And you, like I say, you use it according to what it says. So yeah, but because we use one kind, I don't know what the other. We use the 801. I don't know what the other ones are.
Right. Okay. And
but yeah, in the kitchen.
And I've got a question here. It says, do you accept or refuse repeat requests?
We accept them. We accept every request.
Okay. I'm conscious of time, and so it's probably time for a brief comfort break. Thank you very much, Shona. I think we're going to reconvene at 10 past 3, so 15:10, and we look forward to seeing you in 10 minutes or so. So, welcome back, everyone. I'm hoping that you've had enough time to boil a kettle and get a comfort break. We're just going to move swiftly on to our final speaker of the afternoon, Miss Amy Kiley, who's going to talk to us about implementation of pre-eclampsia biomarkers. So, thank you very much, Amy.
So, good afternoon. My name is Amy Kiley, and I'm a biochemist at Doncaster and Bassett Hospitals. We've been using the SFLIT1 PLGF ratio testing in our trust for just over a year now, and I'm going to give you a little insight into the implementation of it in our laboratory. So I'm going to talk a little bit about our clinical protocol, about the analytical platform that we're using for the analysis, how we verified the two assays, and then how we set up the procedural side of things, both in terms of the clinical staff and the lab staff. I'm also going to talk a little bit about proteinuria and some of the findings we've started to get from our clinical audit of the service. So this is our clinical protocol. We are performing the ratio tests in patients who don't kind of clearly fit the diagnostic criteria for preeclampsia and with hypertension and a PCR greater than 30. But there's some sort of clinical concern for preeclampsia with the presence of isolated hypertension or isolated proteinuria. Just to note that significant proteinuria is defined as a PCR greater than or equal to 30, but in practice we found that the clinical team will also use 1+ of protein on a urine dipstick to find significant proteinuria as well. We're then using the ratio cutoffs of less than or equal to 38 to rule out, greater than 85, greater than or equal to 85 to rule in, with an intermediate result of 39 to 84, indicating that increased surveillance is justified. So that's our clinical protocol. So how in the lab do we provide the analysis? So at Doncaster and Bassett, we didn't have any Roche instrumentation at all. So we needed to obtain a standalone immunoassay analyzer, and that was the E411. And that's what's pictured here. This is the E411 in our lab. And as you can see, it's a fairly substantial piece of kit. So in terms of installation of the analyzer, it was pretty straightforward actually. We went from install to go live in about 6 weeks, and that's including verification of the assays and the staff training side of things. The instrument requires space and it requires power. The software, the kind of user interface, was something that we weren't used to. But actually the staff have found it quite straightforward to use. So there've been no problems with that. It doesn't need to be plumbed in. It's got a liquid waste container and a solid waste container. There's a couple of bulk solutions, that's ProCell, CleanCell and Assist Wash. Reagents wise, the kits come in ready to use packs of 100 shots, and we find them very stable on board. Both assays have lyophilized 2-point calibrators, and the kit insert states that they need a weekly calibration. The instrument itself requires rather minimal maintenance, so it's not a big time commitment to look after, which is good. And just to say that we haven't actually got it interfaced with our LIMS system, which obviously impacts on its use, and I will talk a little bit about that a bit later on. So in terms of the analytical verification, verification is tricky when you're introducing a completely new test. We don't have a comparator method. So what we could do was look at within and between batch precision. So I've just shown them there. That's QC level 1 and QC level 2. And we found both are sort of fairly typical of what you can achieve with most kind of automated immunoassays. The current QC performance you can see there, we have a CV of up to 3.5% for PLGF and 2.8% for SFLIT1. And we do find that the QC is stable over different reagent lots. The only kind of other way that we could show that the assays were performing analytically was to perform a kind of sample comparison with a couple of other labs where the testing was already established. So we did that, and there was a couple of labs that kindly sent us some samples. And we also analysed some EQA. So NEQAS kindly provided us with some samples to analyse. And as far as I'm aware, there's also a WeQuest scheme that's available as well. And basically, after all this, we were pretty happy that the assays will perform to the specification. So we had a clinical protocol, we had an analyzer with the assays working, and now we just needed to finalise the logistics around the kind of test requesting and getting the sample to the lab. So this kind of protocol for clinical staff was produced. So patients fitting the criteria for testing, a serum sample was collected. And for us, this was a separate sample from any other bloods they might want to do in relation to the pre-eclampsias that they might want to be doing using these and LFTs and things like that as well. But we requested a separate sample. And we asked that they also follow our lab's fast track procedure, which basically involves ringing ahead to tell us that they're sending a sample. In terms of turnaround time, we agreed that if a sample was received in the laboratory at either Bassetlaw or Doncaster, so we're actually a two-hospital trust, so we've got maternity services on the two different sites. So if we received a sample at either site before 6 p.m, 7 days a week, the lab would provide the results within 4 hours. So you need to bear in mind that this also includes the transport from Bassett Doncaster, where we analyse the samples. And then results would be available on the electronic report system for the clinical staff to pick them up. So what happens in the lab once we receive the samples? So as I said, we get a call ahead of time to let us know that the sample is coming. And this allows us to perform the quality control on the analyzer. So by the time we receive the sample, we're ready to go. And this is because we found that receiving samples can be fairly intermittent. So we will have some days where we have 3 or 4 and some days where we may have none. So we only QC the analyzer when we know we have a sample to run. Because the kind of assay is performed offline in terms of our automated track system in the lab, it's centrifuged offline and then handed to a biomedical scientist to analyse the sample. As I said, we would analyse any sample received in the lab by 6 p.m, but after 6 o'clock, samples are stored in the fridge overnight and then analysed first thing in the morning. And this is largely because after around 8-9 o'clock, we only have one biomedical scientist on site providing the biochemistry service, so we didn't want to put too much pressure on them in the kind of out of hours period. So for the member of lab staff analysing the sample, it's very simple really. They program the request onto the analyzer and they press start. It's worth mentioning that without interfacing, this does mean that there's no host query to see what tests need to be performed on the sample. We have to manually make sure that QC has been performed and that it's within control. We have to print out the results, manually transcribe them into the LIMS system, and then get someone to transcription check them. Interfacing would get rid of a lot of those problems. But how we've decided to kind of capture it is just with a little audit trail on the results printout. So in terms of governance, we've covered everything. So that is pretty much how we've been doing it for the last year, and I think we're all kind of in agreement here that it's been going well, and I know the clinical team are very happy with it. So as a kind of review, we've been looking back at the data as part of the clinical audit, and I just wanted to highlight a little finding with regards to proteinuria. So the NICE guidance on hypertension in pregnancy states that we should be using an automated reagent strip reading device for dipstick screening. And if the dipstick reads 1+ or more of protein, so I think that's around 300 milligrams per litre on most dipsticks, we should then be using a PCR to quantify the proteinuria. If the PCR is greater than or equal to 30, then this is defined as significant proteinuria in terms of your pre-eclampsia diagnosis. So looking at the patients from our audit from July to November 2020, 95% of them had a dipstick result documented in their notes from the kind of assessment episode. Only 40% of those, the samples were sent on to the lab for PCR. Now, a lot of the samples that were sent to the lab were negative or trace on the dipstick, and there were some that were 1+ or more of protein on the dipstick that weren't sent to the lab for PCR. So I think perhaps we might be looking at needing to tidy up our protocol there and kind of have a more consistent approach about which samples are sent to the lab for PCR to quantify the proteinuria. The kind of other thing to note was that there's actually quite poor correlation between the urine dipstick result and the PCR. So for patients who had a PCR greater than or equal to 30, the dipstick was always at least 1+ for protein. However, for patients with a PCR of less than 30, the dipstick could be anything from negative to 3+, and that's what I've just broken down into the little pie chart there. So the dipstick seems to be a good rule out for significant proteinuria, but a negative for protein on the dipstick is a good rule out for significant proteinuria, but 1+ is not necessarily a very good rule in. And this kind of supports the NICE guidance that if you get a 1+, you do need to send the sample for PCR to determine whether it's significant or not, in order to kind of appropriately guide your clinical decision making. So now I just wanted to bring us back to our clinical protocol. As I said, we're trying to kind of perform a clinical audit around it. And the first part was to look at the appropriateness of the requesting of the tests that we've performed within the last year. So do the patients tested fit the criteria we've set for testing? So do they have isolated new hypertension or isolated gestational proteinuria? So in the 5 months from July to November, we carried out 97 tests on 72 different patients. 61% of the tests were performed in patients who fit the criteria. So they had the isolated new hypertension or isolated proteinuria. 18% of the tests, however, were performed in ladies who already fitted the criteria for treatment for pre-eclampsia. So they had hypertension and they had the proteinuria. PCR was greater than or equal to 30. There was also 21% of the tests that were performed in patients without hypertension and without proteinuria. So that's a bit of a question as to why those were done. So I've had a look at the results for these 3 different sets of patients, and I've broken it down into 3 categories. So the less than or equal to 38 is shown in green, 39 to 84 in orange, and greater than 85 in red. So if we look at the 61% of kind of appropriate requests, so if they're fitting the criteria for testing, 24% had a ratio that ruled in pre-eclampsia, and 68 had a ratio that ruled out pre-eclampsia, with a small number in the intermediate range. Not surprisingly, in the 18% of ladies who already had hypertension and proteinuria documented, there was a lower percentage of the rule out and a higher percentage of rule in. then in the 21% of ladies with, neither hypertension nor proteinuria, we saw a much higher proportion of kind of intermediate results. So there was 35% there fitting into the intermediate category. So we decided to kind of look in a bit more detail into these 21% of patients that didn't seem to kind of fit the criteria for testing at all. Were these tests appropriate? Kind of according to the protocol, they're not, but I do suspect some of them were genuinely needed. And that may be because the clinician was suspicious around the patient previously having hypertension or proteinuria documented. They had other clinical concerns, so headache, edema, or visual disturbances, or they were repeating it because there was a previous borderline result. I do suspect, however, that some of them weren't genuinely needed as well. And this is kind of supported by the fact that 100% of these patients were discharged. But I can see how when you've got a patient in front of you who you have clinical concern about, doing the test can kind of support your decision and may offer some kind of reassurance that it's okay to discharge that patient. Interestingly, some of these ladies were the ones who had 1+ of protein on the urine dipstick. So a sample was sent for the ratio test, and a sample was sent for a PCR. However, the PCR result was less than 30. And this had led the clinical team to suggesting that perhaps what might be a good idea is that they send us a urine sample and a blood sample, and we only process the blood sample if the PCR shows that the proteinuria is significant. So PCR is greater than or equal to 30. So we then had a closer look about the 18% of patients who had both hypertension and proteinuria, so should have gone down the treatment pathway for pre-eclampsia. 50% of those had a ratio that ruled out pre-eclampsia, and 100% of these patients then went on to be discharged. Then the other 50% had either the intermediate or kind of rule-in ratio, and 100% of these patients were admitted. So in these cases, I think doing the test has supported the kind of clinical decision making about what to do with these patients. And again, it raises the issue around proteinuria. So some of these patients had 1+ or more of protein on the dipstick, and that's how the clinical team had determined that they had significant proteinuria. But I suspect if more of those had been sent to the lab, they may have had PCRs of less than 30. So actually they fit the category where testing was indicated. So it raises this issue around urine PCRs and whether sending the blood and the urine to the lab at the same time would be helpful. And we should only be doing the PLGF ratio testing when the PCR is greater than or equal to 30. So what's next? So obviously we need to complete our clinical audit, and this side of it now is looking at the outcome side of things. Our maternity service has put together a business case to carry on with the ratio testing after the ITP funding ends. So they're very keen to keep using the service. I think we've got a little bit of further work to do around dipstick and kind of PCR testing, and how we're defining significant proteinuria. And as I said, associated with this, I think we need to look at the flow of urine samples for PCR through the lab, because we don't really currently treat them as kind of urgent or priority samples in any way. They're often batch tested towards the end of the day. However, if we're going to take kind of a more holistic approach to kind of screening for preeclampsia and use the PCR result to determine whether we do the ratio test, we're going to have to kind of have a bit of a rethink and do things differently. I think after we've done the clinical audit and kind of debrief with the clinical team, I think there may be some little tweaks to our clinical protocol. So yeah, that's probably going to result in some refresher training for the clinical staff, so we can do what we can to improve the appropriateness of testing and get the best value out of the service. So I just really wanted to acknowledge all those who've been involved in the setting up of the service at our trust. So we have an excellent laboratory team, and that's sort of been led by Dr. Spores and Mr. Bell. We've worked very closely with the clinical team, so Tony, the lead midwife, and Dr. Vimalama, the obstetrician, and we've also had significant help from the Roche team around sort of training the clinical staff and that side of things. So thank you to Sue for that. And that's it really. So thank you for listening, and thank you for inviting me to talk. And are there any questions?
Thank you, Amy, for a very clear talk. I've got some questions for you that come through. So one of them is, why don't you skip dipstick urine protein screening and move directly to PCR?
It's a very good question, and I suspect we may consider that. But I think, as I said, a negative on the dipstick is kind of a good rule out for not needing to send a sample to lab for PCR. So I think we'll. Oh.
So one of the things that has changed is that you can diagnose pre-eclampsia without the presence of proteinuria. So it's not entirely necessary anymore. So it may be important to consider that some patients may have abnormal renal function or have abnormal liver function or have a small baby, and that they don't need proteinuria to have the disease. And so it might be important to consider that in the workflow, just moving forwards. Just making that point that, you know, the definitions have changed, not reasonably recently. So, you know, it may be that some patients may be disenfranchised by that cutoff, as it were. There's a question here about, is there consistency between your performance on UK NEQAS and WEQAS, whatever they are?
So we're currently only registered for the NEQAS scheme, so I don't know how WEQAS performs.
Okay. Given you had a significant amount of retesting, 97 tests on 72 patients, would you please comment on the clinical impact of retesting?
Difficult for me to say, being in the lab, but I mean, we haven't really looked a whole lot into the retesting side of things. According to the protocol, you can retest patients, but it depends if they've previously had an elevated result. What is doing it, again, going to tell you, I'm not really sure. And I think we saw in the talk at the beginning, there's not a lot of data around retesting and what it's valid. Yeah.
Okay. Do you think there's going to be a need to change the test availability to a 24/7 service, or do you feel that it doesn't need to be tested with a quicker turnaround time? Should labs be offering this sort of testing on a 24/7 basis, is the question.
Well, I think really we've got to be led by the clinical teams on this, and are they feeling that they need to make these decisions that acutely? So yeah, I don't think that's necessarily for the lab to decide.
Yes, okay. I'm looking for other questions. So I think you had some information on the traceability, right? It's been standardized against something, is that right?
So I think in the kit inserts it says it's standardised against another commercial method. Right. I don't know a huge amount about that, but I'm assuming it's the same as with a lot of assays. There's no kind of standard reference material by which you can reference the method, so that might come in time.
Okay. Okay, well, Amy, thank you very much indeed for your questions. I'm going to bring Jenny, I hope, back on board, and then we'll try and do a group conversation soon. So, Jenny, welcome back. There's a list of questions.
Thank you. Good afternoon.
Are there plans? Well, no. So, is Parrot 2 using both Roche and Quidel platforms, or just one of them?
Yeah, so it's running in sites that have implemented both Quidel and Roche. So some of the sites for Parrot 2 are using the Quidel platform, and some of the sites like ours recruiting to Parrot 2 are using the Roche platform. So we know that both tests perform very well with very similar sensitivities and negative predictive values, rule in, rule out. So I think it's going to be a really useful opportunity to see the value of repeat testing for PLGF based testing in general, and potentially any added value of having the flip test as well as just the PLGF.
Okay, there's a question here that I think will be quite familiar to you, Jenny. We're generally quite good at diagnosing pre-eclampsia through clinical assessment. What value would this test offer to our service?
Yeah, so that is a very familiar question, and I think for lots of women who present with preeclampsia, the diagnosis is reasonably straightforward, and women present with new hypertension, new proteinuria, other signs of fetal growth restriction or end organ disease, and we don't need a test to confirm the diagnosis in that group of women. That's absolutely true, but there are a significant number of women, and I would say it's as many as 1 in 3 of the women who ultimately end up with a diagnosis of preeclampsia, where the diagnosis is not straightforward. We've just been talking about the issue of proteinuria. A lot of women who develop placental disease with evidence of fetal growth restriction developing or other end organ problems don't have significant proteinuria. And I'm actually staggered on a weekly basis by how often I see women with very abnormal angiogenic marker testing, abnormal PLGF ratio tests who don't actually have proteinuria, and sometimes it never develops despite the fact they get other significant end organ disease. And so if nothing else, we have shown by using this test and developing experience that our current diagnostic criteria are woefully inadequate. Also, there are many women who will develop particularly perinatal complications where the maternal features of the disease happen quite late, and there's an opportunity to intervene much earlier when you've got a diagnosis that's made on a test that's much closer to the pathophysiology of the disease. So I'm absolutely with whoever has asked the question that for a lot of women the test is not necessary, and our clinical management will continue the same. But I would urge you all to consider that the having a diagnostic test that actually measures the pathophysiology or is much closer to the pathophysiology allows us to make the diagnosis in a much more accurate way in a broader group of women, and that has a big impact on our care and keeping these women and their babies safe.
Yeah, I can absolutely agree with you, Jenny. It's useful to have a number as opposed to relying on intuition. So does chronic kidney disease affect the interpretation of the results?
So that's an excellent question, and there's quite a lot of debate on this at the moment, and there's some new data coming out from Lucy Chappell's group, and there are other bits of data suggesting that the renal handling of both FLIT and PLGF might be altered in women with chronic kidney disease, and the numbers of women inevitably with chronic kidney disease included in the other bigger studies are obviously quite small. So I think those of us who look after women with chronic kidney disease, I use the test all the time in women with chronic kidney disease, and I find it very useful. But we are being very cautious about its interpretation on the basis that we still have limited information about exactly what thresholds we should be using in that population of women. But my feeling is that we probably overdiagnose what looks like preeclampsia. We probably overdiagnose in women with chronic kidney disease currently. And so what we need to really work out using angiogenic marker testing is how to make that diagnosis more accurate and really relevant for that patient group. So we need more work in that area to be absolutely confident about what thresholds we should be using.
I apologise for the background noise. The heavens have just opened in Oxford.
Yeah.
Are there plans to look at placental or work at ways of identifying placental abnormalities earlier than 20 weeks? For example, testing at 12 weeks to predict mothers who may go on to develop preeclampsia or deliver smaller babies.
Well, the Fetal Medicine Foundation already includes PLGF as a first trimester marker alongside PAP-A with uterine artery Doppler and blood pressure, which has got has got good accuracy for the detection of women who will go on to get very early onset placental disease in later pregnancy, and obviously that includes women who get early onset preeclampsia and fetal growth restriction. It doesn't have great predictive value for the wider group of women who get slightly later onset preeclampsia, and indeed those women who get preeclampsia in the last 3 or 4 weeks of pregnancy. But again, more and more work coming out on this all the time. My feeling is that there are 2 groups of women who get abnormal angiogenic markers during pregnancy. There's a group who have very low levels of PLGF from the beginning of pregnancy, who are at very high risk of developing complications. And then there's a group of women who get a normal increase in PLGF over the early and middle part of pregnancy. Manu and I both showed the graph with the classic rise in PLGF towards the middle of pregnancy, around 28 weeks, and then it declines. And in the women who get preterm preeclampsia, those women who get preeclampsia before 37 weeks, it declines much more rapidly, and that's when you see soluble FLIT increasing. So I think there are different populations, and the more we study these biomarkers, the more we'll understand about their use in both early and late pregnancy.
Okay, so is the clinical outcome in preeclampsia mums without proteinuria better compared to preeclampsia mothers with proteinuria?
Well, if you'd asked me that question, maybe 3 years ago, I'd have said, well, proteinuria marks, significant endothelial disease, and those women are more likely to, have more advanced endothelial disease, more likely to get sick. I think now we're using better ways to actually make a diagnosis properly. I think we've seen more and more often, as I said before, that women present with many different parts of this syndrome, and some women have, really bad hypertension, hardly any proteinuria, if no proteinuria at all, and develop very significant end organ complications. Other women get very little in the way of hypertension, very significant proteinuria, and go on to develop end organ complications. I think, Jim Roberts says this a lot, professor of preeclampsia in the US, that when you've seen 1 case of preeclampsia, you've seen 1 case of preeclampsia. It's such a heterogeneous disease, and that's why we need to use all of the clinical features of the syndrome, including, in my view, angiogenic marker testing, to identify those women at highest risk. But anyone who thinks they can predict which women are going to run into trouble, in my view, is naive. All of the women who start to bubble along the path towards preeclampsia are at risk of developing severe complications.
So, completely agree with you. So, Chris Redman, who's who's the professor of obstetric medicine at Oxford, the emeritus professor now, coined the term non-proteinuric preeclampsia in the late 80s, and it's bizarre. He sits there looking very smug now. So the next question is, many complex cases present towards the end of pregnancy when this test should not be used post 36 plus 6 weeks. Is there a concern that there could be a temptation to misuse this test when the results are less reliable?
I think there's always a temptation to misuse tests, unfortunately, and I think it's important that we use the test for the purposes for which it's been demonstrated to be effective, and that's in the gestation up to 37 weeks gestation. And so we know that because of the overlap between healthy pregnancy and pre-eclampsia in late gestation, and also sorry, my computer's pinging at me, and also the fact that the etiology of the conditions there's a continuum between preterm preeclampsia and the condition that we see in late pregnancy, term preeclampsia. It's hard to distinguish them, but the pathophysiology is probably subtly different, and the angiogenic markers have not been demonstrated to be effective as diagnostic or prognostic factors. And I think we all have to recognise that 2 out of 3 of the women that we see with preeclampsia will get the disease at the end of pregnancy, and that group remain a very, very important part of our clinical work. I think the difference with that group is that once we've made the diagnosis using clinical features, which at the moment is all we've got to go on, we have an intervention which we can very quickly and safely use once we're beyond 37 weeks.
There's another question here saying, should we be keeping patients on the assessment unit until their ratio result is back? Is it safe to discharge these women home and recall if abnormal?
So, again, great question. I think it very much depends on the clinical assessment, and the test is only one part of that clinical assessment. So I think you have to assess the woman. I kind of do this head-to-toe assessment, starting with symptoms, blood pressure, what's the baby doing, what are the other blood tests doing, and if a woman is well, her blood pressure's within safe limits, fetal assessment is reassuring, then we would typically let women go home, and then often recall women back if their blood test is very abnormal. We also do manage a number of women as outpatients, even once that we've confirmed the ratio is normal and we've made a diagnosis, which we did pre-using the test as well. So in some circumstances, we would offer women outpatient management, and we counsel all our women about the possibility of developing severe and unpredictable complications associated with their preeclampsia, and we offer inpatient surveillance or outpatient surveillance if we think that's safe. We do that a lot in conjunction with home blood pressure monitoring as well, and the reason for me for admitting women whilst you're trying to make the diagnosis often is because it's unclear what's going to happen with blood pressure sometimes, and so making sure that blood pressure is treated and maintained within safe parameters is the priority. So yeah, that was a long-winded answer. So I think in some circumstances, assuming all of the parts of maternal and fetal assessment are okay, it is absolutely all right to await to let women home and await the results, as long as that's obviously reviewed in a timely way. Okay,
Jenny, I'm conscious that there are lots more questions here, but there's a couple of questions, biochemistry questions. So I'm wondering if it's possible to bring Amy and Shona in for the last few minutes. One of the questions was about stability, Shona, about the E4 and something and the E801 and the stability of the tests.
Yeah, so there was an earlier question at the end of my presentation about the onboard kit stability. Yeah, which I couldn't answer at the time, about the difference between the two or the 3 different analyzers, and there is a slight difference between the onboard kit stability between the different analyzers. So for both PLGF and ESPA, the 801s have a 16-week onboard stability, and the E411s and 602s have a 12-week onboard stability. So once it's opened, it's they are slightly different, but longer than I said.
Okay, and Amy, do you waste much reagent? If so, is there any benefit to not testing samples that have been taken in patients that are awaiting urine protein results? I think we've addressed this.
No, we don't tend to waste reagent.
That's my fault, not paying attention. And then the final question for Jenny, is one of the important things of this test is ruling out pre-eclampsia before 37 weeks to reduce preterm birth rate, because more than 50% of preterm births are iatrogenic. Do you agree? And what advice do you do to, say, do a repeat at, say, 36 weeks and 6 days to see how long they, to buy some time for patients before the line in the sand is drawn?
Well, we're not advocating any repeat testing at the moment, because I think we're still unsure exactly what the role of repeat testing is. So I don't routinely retest. Now, that's not to say I don't retest, I do. And the circumstances in which I often retest are those women where the clinical diagnosis is absolutely impossible. And that's my population of women with hypertension and proteinuria, which makes up a lot of my workload. So that's women with diabetes, women with chronic hypertension, women with kidney disease. And so, in years gone by, we would often think, victory is ours. We've got to 35, 36 weeks in this high-risk pregnancy. Let's just, cut and run, as it were. And I think that's not good enough now, because we've got much, much better ways of assessing, certainly the placental disease. And that's not to say that women often need delivery for maternal reasons preterm, but we now have a really good way of assessing placental disease, and placental disease that might be driving changes in maternal condition. So when we see changes in maternal condition, hypertension, proteinuria, etc., then for me the issue is, right, diagnosis, is it being driven by placental disease? Is the ratio normal or abnormal? If the ratio in that situation is normal, and the rest of the maternal syndrome or the maternal features can be managed safely, then we're getting more and more women, I think, to gestations of 37, 38 weeks, which makes a huge difference for the women and for more importantly for those children. Yes. And we start converting some of those preterm births into deliveries at 37, 38 weeks. So for me, that's one of the huge advantages. The other thing, and I said it in my talk, is you have to work very hard when you've got abnormal tests to make sure that you're watching women very carefully, but not just jumping in and delivering just because you've got an abnormal number. And I think Manu and I have said that repeatedly when we've been teaching people, and I think that's a really important point. And we've demonstrated time after time in the clinical studies and in the clinical evaluations that is possible, that you don't increase preterm births using this test as long as you're using it appropriately, and everyone who's using the test knows what they're doing.
Okay, there is a question, quite a popular thumbs up question about how we clarify how PLGF-based testing will be funded in the future in England, and I'm going to ask Julia Eads to, oh, there you are, that's more as if I imagine. I'm going to ask Julia to comment on that. Julia.
Yeah, thank you, Manu. It is a very common question at the moment. So the funding via the ITP, the Innovation Technology Programme, is going to finish on the 31st of March, and funding via the MedTech funding mandate commences on the 1st of April. However, each providing trust has to gain agreement with their commissioner at the CCG to reimburse them over and above their maternity block contract. Alternatively, you can self-fund via an internal business case. So there are a few options for you, but time is quite limited. So we really encourage everyone to start those conversations now. The MedTech funding mandate has gone out and been communicated to all of the CCG accountable people and the directors of finance and procurement at trusts. So people should be expecting to have these discussions, but we really encourage you to do so. The creation of a business case locally is essential. So that is the first thing to do based on the data that you have created during the ITP, and then take that forward to the CCG if you want to access that reimbursement. So yeah, I hope that's answered the question. Let me just add, actually, sorry, the AHSNs and the outcome specialists at Roche are here to support with that as well, so we can help you.
Okay, I'm very conscious of time, so I'm going to thank everybody who's spoken. I'm just going to finish with the summary slides, I think, is the next thing to do. So I think, well, I think we can say that Jenny gave an excellent overview of the pathogenesis of pre-eclampsia and outlined the clinical studies that have shown PLGF-based testing is superior to clinical acumen alone. Got to thank Shona for talking to us about giving us insights into assay performance and clinical models, as well as the benefits of sample exchange between laboratories, and Amy about giving a really interesting overview of the practicalities of implementation. And I think at the end we can sort of say that PLGF-based testing, I think the evidence is pretty clear that it's more accurate than a traditional clinical assessment, and especially in those patients that are just not, not straightforward, not what we were taught at medical school. I think there's some clear advantage about I think I want to go back. I think it shows some significant advantages in stratifying patients into high risk and very low risk. We looked at sample stability and inter-analyzer variability, and it's been shown that workflows can be integrated into laboratory practice reasonably straightforwardly. So next steps and next slide. The implementation needs to become embedded, and as Julia said, there's the AAC Strategic Finance MedTech funding mandate to continue testing after the 1st of April, and I think the AHSN and suppliers will help. And we need to build business cases to continue, and I think it's really important that people start to engage with that. And if I can, in the last 3 minutes, if I can bring our speakers back online, there's just 2 more questions that I want to ask. So one of the questions is there anything around funding in Wales where ITP does not apply? Back to Julia, who thought she'd got time off.
You're bringing me back in. Okay, so at the moment we're trying to work with Wales, Scotland and the island of Ireland to support implementation of the tests. However, there is, as it stands, no national funding programmes in place. So it will be a trust by trust or health board by health board basis to collate a local business case. And we're really trying to share the learns from England in helping them do that.
And I guess finally, I think, well, Jenny, I'm going to ask Jenny to reiterate this, that, it's important we treat the patient and not the number. Do you agree?
Yes, yeah, and I think I hope I've said that at least twice this afternoon. I can't say it often enough. This is an adjunct to clinical assessment, and it's when you've confirmed the diagnosis, you need to then monitor that pregnancy very carefully and make decisions based on maternal and fetal assessment, not on the number alone. And we've seen severe complications happen in women with ratios of 74, that just happen to be below that 85 cutoff, and we've seen women with ratios up in the hundreds who last for several weeks before any complications arise. So we make the diagnosis earlier with this test, and so therefore we have to watch and be patient and monitor these pregnancies carefully to get the best outcomes.
Okay, and so as we wrap up with the last minute and a half, I think it leaves me to say thank you very much to Professor Jenny Myers and Shona Haslam and Amy Kiley and Julia Eads for giving some really excellent talks and some really excellent answers to what has been a very interesting afternoon. I think that the questions that we haven't had time to answer, that we will answer them, or they will be answered by return of email. So it leaves me to say thank you very much and thank you for attending.